The Pitt episode 9, I heard the ending on this is a bit traumatic. Huge thanks to Grammarly for sponsoring this video. Let's get started. I'm really glad they show this because members of the environmental staff are also members of the team, and they also have to deal with loss. A lot of times they're forgotten or overlooked on other medical shows.
That's as hard as it gets. We do these debriefs to try to give a sense of closure, meaning to difficult cases so that they won't linger.
So in the ER, this is a little bit unfamiliar to me. Usually what we have are called morbidity and mortality rounds, where we discuss patients who have passed, where we try to learn from the situation and improve for future patients. I didn't know that in the ER it happens literally the time the patients pass.
The kids you'll lose will linger. So what do? I did my residency at Big Charity in New Orleans. And day one, I got a kid, 5-year-old boy, accidentally shot by his brother, playing with dad's gun, worried he was gonna get in trouble, right up until he coded and died. Then I asked myself, like, what do I do with this kid? Where do I put this feeling? And I found myself walking all night. I was walking and walking and walking, and I found myself back at the gates of Big Charity Cemetery, and I'm looking at all those mausoleums and those crypts, and I'm thinking to myself, okay, well, that's what I need. I just need a safe place where I can put these feelings
We got
in.
patients throwing punches in chairs.
I was just about to say, the fact that they have time to do this while on a shift in a busy ER is surprising.
Hey, Olsen, that took you long enough.
I did find it strange that the security guard went in to grab the rest of the staff, while the security guard should have been the one breaking them up.
How hard is it to put a mask on your kid? He has allergies. Fauci zombies. Allergies.
Oh!
Hey! Hey! That's enough! Jesus almighty, I don't believe what I'm seeing. What do you people think you are? Huh? This ain't Philly. This is a hospital, for Christ's sakes. What's the matter with you?
You tell them.
This is ridiculous. All I did was offer to put a mask on her child who's been coughing.
Oh, her tooth's gone.
And now I'm missing out my goddamn
First of all,
like
masks are bull.
Just separate them. That's the answer here.
What happened to the tooth? Did you swallow it?
I don't think so.
I think it's still in my hand.
Sure is. I hope you both have all your shots.
Fight bite.
What do you mean, like vaccines?
Jesus, please don't stir this pot. Let's take these ladies back and get them treated separately.
Maybe someone should call the police? Yeah, you gotta be careful with fight bites because the human mouth is notoriously polymicrobial. So lots of bacteria, lots of different bugs in there. And if you get some of that into the knuckle and then you close your hand, that can close the wound, prevent it from escaping, and therefore the bacteria ends up trapped, potentially leading to cellulitis, septic arthritis, osteomyelitis, things that you would need IV antibiotics for, potentially a stay in the hospital.
Type 2 fracture into the dentin. Seal with dental cement.
Wow, we need Dr. Rubenstein here, stat. I have zero idea how to handle that tooth situation.
You got yourself a fight bite, which means a couple things. First, we need to determine if the bite extended into the joint space. If it did, you're gonna need IV antibiotics and a trip to the OR to see a hand surgeon.
It's funny we just said this.
How can you tell if it's bad?
Great question, Dr. King.
I'm sorry?
I am going to inject some sterile saline into your knuckle joint, which you won't feel because of the anesthetic. If it comes spraying back out of the bite wound, we'll know. Ready?
I guess.
There she blows.
Are you serious? You hear that? I gotta have surgery thanks to you.
Good! You assaulted me!
Damn right. And now that next time you'll keep your masks and opinions to yourself.
Why is she so anti-mask that she's willing to punch someone in the face over it?
3 grams Unison IV.
That's a pretty broad spectrum antibiotic.
Oh, did you want me to tell the surgeons to go no mask for surgery?
What?
Well, those of us who save lives for a living believe strongly that masks minimize risk when it comes to spreading disease and infection, but I want to respect your beliefs.
Noah told me about this line and it completely went over my head. I just nodded along, but this is what he was talking about. So he wrote this episode?
What do you think? With or without for surgery? Without?
I went with.
Good call.
Because they work.
Robbie, critical case flying in, possible MDMA overdose, high temp, en route from Pitt Fest, 5 minutes out.
MDMA overdose is really serious and needs to be treated quite quickly because it can be lethal. You could develop electrolyte abnormalities, hyponatremia that could be very severe, seizures, you could vomit and aspirate your vomit. That's how a lot of overdoses happen when someone is not under medical supervision.
Pitt Fest OD.
Keely Ralston brought to the first aid tent at Pitt Fest with altered mental status and fever. Temp too high for a field thermometer.
So hyperthermia, you gotta cool the patient, you gotta make sure their breathing is secured. As far as seizures, as far as chest pain, all these things, you gotta get benzodiazepines on board in order to relax the patient. It'll also help break a potential seizure. You also worry about serotonin syndrome in patients like this, where benzodiazepines and cyproheptadine are agents that you might give in a scenario like this. I don't know when the patient consumed the MDMA, but usually if the patient is awake and the airway secure, there is a conversation about giving activated charcoal. I don't think that's happening here.
We gotta cool this lady down.
Get some ice packs, head, neck, groin, send off a rainbow.
Yeah, so you know how I always talk smack about ice baths because people in the podcast space like to act like they cure everything and fix everything and make you superhuman? MDMA overdose and hyperthermia is when you need an ice bath to actually cool you down.
Heart rate 132, BP 210 over 120.
So in a situation like this, when a patient's dehydrated, you gotta be really careful about hydrating them because of their sodium status. Usually if someone's just mildly hyponatremic, if you fluid restrict them, they could actually recover in the next 12 to 24 hours. Perhaps if they're really dehydrated, you could give them some normal saline. But even in scenarios like that, you gotta be very careful. You could really mess with someone's sodium level in the incorrect way. You also may be overstating their dehydration because some of my residents in the past have looked at their heart rate and said, oh, look, they're tachycardic, they must be severely dehydrated. Remember, tachycardia could be because of dehydration or because of the overdose of the medicine. So you don't know what's causing that fast heart rate. And then in patients, obviously, who have severe hyponatremia, so severely low sodium level, you have to give hypertonic saline, but you have to give it in very specific time doses and really often recheck to make sure that you're not correcting too quickly, because that could also yield all sorts of negative outcomes.
4 of Ativan in the field.
Pupils are dilated, definitely MDMA overdose. Dr. Mohan, how do you want to treat the BP?
Beta blockers?
You never want to give beta blockers in a situation like this. There's been some controversy about using labetalol. General guidelines still shift away from that. If it's the only thing available, maybe, but benzodiazepines are still the main route to go there. And I don't think you need anything else.
No, unopposed alpha could kill her. 4 more of Ativan, please.
There you go.
Damn, core temp 107.3.
Core temp measurements are exactly what you need in this situation, not just superficial temps.
I'm a part of the street team here. It's a group of doctors and nurses who go out in the community and help people who can't or won't ask for help. Addicts, unhoused, runaways. And I'll be honest with you, Piper, I think you need some help.
What are you talking about?
If you're in trouble, we can help you.
I'm not. Okay? And if we're done here, I think I'd like to go.
Will you at least take a look at this? There's a list of resources on the back.
I don't need that.
Yeah, I know you don't have a phone, but if you could just take my number, okay? You never know.
Where's Laura?
How about taking the pen? If you ever feel unsafe or in danger, call this number. It's a national hotline. There's somebody on the other end 24/7. A trained professional who can help with anything.
I have all the help I need. I want to go.
These are great resources that she's giving her because sometimes people don't feel safe to speak out in the moment, but perhaps later will have a change of heart. And them being able to access those resources without a phone is of utmost importance.
She'll be back. Only she'll have slipped a little further.
Sometimes it takes a few visits.
How can I keep her here? You got anything?
Maybe Kiara has a social services card to play. She was by Trauma 1 last I saw her.
Brilliant. Brilliant. Thank you.
That's why I'm here. To be brilliant.
I would have verified her ID a little bit more strictly to make sure she's of age, that she is who she says she is. It's very easy to get a fake ID if you're not knowing what to look for.
1, 2, 3. Gentle, gentle, gentle.
Houston, we have splashdown.
Good luck. See you on the next one.
Yep.
Temps down to 107.1.
How long does she need to stay in the ice, Dr. Santos?
My PB in the ice is 13 minutes.
Dr. Santos.
Until her temp is normal.
Wrong, you pull her out at 102, otherwise we could overshoot and cause hypothermia.
Same thing for changes in temperature. As with the sodium level, you got to be careful of overcorrecting too far.
That's another for Ativan. Rectal temps down to 105.
Okay, moving in the right direction. We might get lucky here.
Obviously, you also want an EKG on a patient like this to make sure that they're not having an active heart attack.
Walter Purnell, 52, walking his dog in the crosswalk, got struck by a Chevy Impala at low velocity.
Ooh.
Ambulatory on scene, no KO, no neck, chest, or belly pain, good vitals.
Whoa, major road rash.
Yeah, the car didn't hit me so much as throw me, but I slid for a good 10 feet. Of course, this is the first day I've worn shorts all left in here.
No deformity at the knee or ankle. Distal pulses intact. 4 of morphine so far.
So he's giving a lot of really good information, signaling that there's no bleeding internally, there's no major orthopedic injury, there's no neurologic injury because he wasn't knocked out. But you don't want to rule all those things out. Those are just good initial steps in order to start ruling out conditions.
Is that the driver?
28-year-old lady had her seatbelt on, clipped the guy with the dog and went straight into a telephone pole. Blood's from a scalp lac. Also completed chest pains.
Scalp lacerations bleed a lot. There's a lot of small blood vessels there, so there's a lot of bleeding.
Heart rate's a bit tacky, 112. BP is fine.
Paul, are you in any pain right now?
Yeah, gonna hurt.
Witnesses say she was driving erratically before the crash. No ETOH on her breath. Maybe drugs?
Could also be something as simple as hypoglycemia or hyperglycemia. You got to be careful of jumping to conclusions that someone is abusing substances, but at the same time check, because you got to rule out all scenarios very quickly in a scenario like this.
All hands on deck. You ready?
Ready?
All right.
Okay, here we go. 1, 2, 3.
Estás poniendo viejo. I heard motor vehicle collision with chest pain and altered mental status. ¿Qué más?
Meet Paula. Restrained driver versus telephone pole. Altered before the crash, good BP, but tacky.
Second line, I'm running a liter of LR, wide open.
Still tacky at 115. BP's 180/72.
Airways patent.
Good breath sounds bilaterally.
Pupils are equal and reactive.
So they're checking to make sure that her lungs are working well and there's no pneumothorax that's there. The pupils being equal and reactive to light appropriately. That will show you that neurologically that there's no drastic changes happening.
Paula, do you know what today's date is?
Sats 94%.
How about the city we're in?
The fact that her sats are 94% is a bit concerning, especially with how high her blood pressure is. I mean, getting an EKG here is of utmost importance.
Bruising on the chest.
She might have blunt chest trauma.
Possible sternal fracture.
Pericardium's clear.
Good.
So pericardium being clear means that there's no cardiac tamponade, so you're ruling out pressure onto the heart from a bleed into the sac surrounding the heart.
Pan scan, head to pelvis, EKG, troponin.
Yeah, so they're checking the internal organs by getting scans, they're checking bones, and they're getting the EKG and troponins to rule out a heart attack. I don't know why the patient's so confused. Obviously, getting a chem panel and a finger stick would have gone a long way to telling us if her blood sugar was appropriate.
Good news, Mr. Purnell. Your heart, lungs, and belly all look good.
Yeah, just the leg.
Woo! This might be a road rash record. We might have to bust out the tape. So the knee looks stable. There's no laxity to suggest a torn ligament. I think the pain's probably just from the road rash, but let's get an x-ray just to be sure.
Some more morphine?
You're a wonderful human being.
Let's start with lead, no more than 30 cc's. We're gonna try a topical anesthetic to numb the raw skin before we start picking out all the gravel.
Yeah, you want to put a topical anesthetic, but also you can think about just saline rinsing the leg off. That will get you a long way. Back to the pit in just a second, but first I want to tell you about Grammarly, an AI tool that works where you work so you can craft quality writing faster across different platforms. As I've seen in the pit, there are constant clashes and miscommunications between the doctors and hospital administrators. I think if the Pitt used Grammarly to write their emails and messages to staff, maybe it would help clean up some of those miscommunications in their very high-stress workplace. I actually use Grammarly all the time to help me write emails to my team. A free feature I love is called Quick Fix, which polishes my writing as I go. With the press of a button, I can accept the suggestions all at once. So easy. They have pro features too, like sidebars. This allows me to highlight a section of my writing and review several options for how to improve it. This can make my long, blabbering email to my editors come in much more succinctly. I also love the setting goals feature that allows me to tell Grammarly who I'm speaking to and what kind of tone I'm aiming for. These tools improve my efficiency, but also maintain my voice. Grammarly works where you work with integrations in over 500,000 apps and websites, allowing you to stay in the flow. Sign up and upgrade to Grammarly Pro to level up your productivity. You can actually use the link in my description for 20% off Pro right now. Really great deal. All right, let's get back to the pit.
Crosby! Crosby! Ow! Drop it! Drop
Oh, no.
Whoa.
Fourth year medical student, come and save the day.
Crosby! Crosby, come here, buddy! Come here. There you go.
He... Why are people... This is weird. This is a weird addition. Is that a clapping moment? Like, let it outside.
Oh my God, there are literally hundreds of different MDMA pills.
There's more than that probably, because a lot of times they're made synthetically in someone's basement or they're like makeshift labs, so you never know what you're getting. And sometimes they're even laced with things like fentanyl.
And the milligram dosage range is all over the place. These names, BMW 5, Jurassic Park, Red Superman.
Well, why is she seizing?
Febrile seizure?
No, her temp is down. Maybe she needs more Ativan.
It could be serotonin syndrome. It could be the sodium levels.
She's had 20 already and her vitals are stabilizing.
Another 4 of Ativan and prepagram of Keppra.
I don't think this is a CNS problem. She needs saline. We don't have her labs back yet. At festivals, you dance for hours, you sweat, you drink gallons of water, but nobody thinks to replenish their salts.
I mean, they should have gotten the results back by now. It would have came back much quicker.
It's low sodium, hypernatremia. She needs 100 cc's of hot saline.
We don't know her sodium levels.
Just drop 100 cc's of 3% and have it ready.
That is what you would give for someone who is markedly hyponatremic, not necessarily with mild hyponatremia. And to assume that that is a seizure from the sodium level versus serotonin syndrome is a bit tricky. In a situation like this, you're probably better off waiting a couple of minutes for the sodium level to come back and breaking the seizure with the Ativan.
And prepagram of Keppra, now.
You also don't want to give some medications if people are agitated, like haloperidol, because that could impact issues with heat, with heart arrhythmias, etc.
Start the Keppra, please.
It's not gonna help.
Problem 1. What are you doing? Got it.
What? This is her first day. She needs to chill. I can't. Look, like, there is no need. It could totally help the patient, but you just don't know yet.
Thanks. It's hypernatremia. Serum sodium is critical, only 112.
Knew it.
Okay, I'll push the other 50 cc's.
What the hell?
She's seizing.
You think? How long?
About 3 minutes.
Why did you not come get me? Hello, I was across the hall. I was 30 feet away. What has she had already?
It's hyponatremia. We pushed 100 cc's of 3% saline. That did the trick.
Again, why did you not come get me?
It was my fault. Yeah, I wanted to keep going with Ativan and Keppra, but Dr. Moen had an excellent idea to treat for hypernatremia even before her labs came back.
That's not a great idea.
Temps down to 102.4.
Good call, Dr. Mohan.
I literally said just a couple more minutes, you get the lab back.
Another minute and we'll de-ice her. I am going to take that minute to try to instill in Dr. Santos a very clear understanding of what her role is here and how she's expected to function.
Dr. Langdon.
Dr. Santos. When I say doctor in such a fashion, to draw attention to the ridiculous fact that you have enjoyed that title for what, 90 days? So yeah, I'm confused. Is it hubris or ignorance that makes you think that you know more than other residents that have 2 to 3 years more experience and have helped thousands more patients in the emergency department than you have? Not to mention the over 500 hours of advanced training with lectures in simulation labs with senior faculty instruction. It doesn't matter.
He's very angry.
Your job is to shut up, listen, and learn, because so far today, the only thing you have been successful at is proving repeatedly that you know nothing.
Dr. Langdon? Is the patient stable?
Temps 1 and 2, just about to take her out of the ice.
Proceed. Dr. Langdon, a word, please.
A little bit harsh, but she's stabbed people, she's accused people, she's made mistakes. Like, She's burst someone's lung open in one of the first episodes. She accused a patient of touching their child inappropriately with limited information. Oh my God.
Where does it say that shaming, belittling, and insulting are effective teaching tools? Let me just tell you, harassment has zero educational value. You're feeling upset? She's getting under your skin? Check yourself. Take a break. I've been watching you ride her. This kind of behavior will not be tolerated. I don't want to see it.
I'm sorry. It won't happen again.
There's a lot of doctors who teach that way routinely. Like, obviously, he's having a stressful day. They're having a stressful day. It's really bad. But there are doctors who do that all the time and belittle staff and belittle residents and junior physicians. It's terrible. So yes, teaching with fear is not valuable. You need to be able to get on people's level and try and motivate them to do better, as opposed to demotivate them with fear and belittling, as my man Noah just said, or should I say Robbie.
How's she doing?
Still with some pleuritic pain.
Oh, hey, Paula. I'm Dr. Collins. Your CT shows that you have a broken sternum. That's your breastbone right here. Probably from the shoulder belt when you crashed your car.
Crashed my car?
And hit your head. With a concussion, sometimes you don't remember, but your head CT doesn't show anything serious.
I'm trying to think of what was the issue that she got a UTI medication. They probably gave her Macrobid or Bactrim based on a bacteria in her urinary tract. I'm trying to think what it could be that made her so out of it. Could it have been pain from a kidney stone? I can't even put it together.
Hey, Dr. McKay?
Just get the bed out of 15.
A patient you saw this morning came back as an MVC, sternal fracture, slightly concussed.
Oh no, Paula, do you remember me?
Look familiar.
I was your doctor this morning for your bladder infection.
Sorry, I'm a little bit.
Still tachycardic 115, BP's 124 over 78.
There's no bleeding anywhere on the CT. Chest and abdomen clear apart from the sternal fracture.
We'll probably still tacky from the fracture pain.
She doesn't seem like she's in a lot of pain though.
I know you hear me. You can pretend you don't, but I know you do. This glass might be bulletproof, but it ain't soundproof, huh? Hello?
I mean, you have to de-escalate before it escalates.
Sir, what is the issue?
Why is she the security guard, the nurse? She does everything.
I've been here all day, and you people have done nothing to help me. You know, unlike most of these losers, I have insurance. Good insurance. And I pay my taxes, which pays for them to not have any insurance.
Sir, you've got about 5 seconds to change your whole attitude before security and the police get involved.
I'm leaving.
Hey! You are absolutely free to go, but if you do, you will be leaving AMA against medical advice. This form states that I have advised you to stay and complete your evaluation, but you are choosing to leave, understanding and accepting all risks of heart attack, stroke, disability, and death.
This is funny, but we actually do have to do this. And if a patient doesn't even want to hear this, it's considered an elopement, and you have to document that.
What's going on?
Car crash, Pitt Paula just went south.
BP's crashing 84 over 62, much less responsive.
I mean, she's either bleeding or having a heart attack or having some congestive heart failure episode. Obviously, they ruled out infection. At least I hope that they did. So those are the only things that I can imagine.
Set up for intubation, and McKay, get Robbie in here.
I'll call ICU and get her bumped ahead of Joyce or Sickler. She should get the next bed.
Yeah, between the hypothermia and the seizure, she's gonna be out of it for a while. A similar thing happened to a friend of mine.
Is that what made you think of hyponatremia?
Look, I know you value evidence-based medicine, but sometimes experience counts for something.
Hyponatremia is evidence-based medicine. What is happening right now? That's literally part of the algorithm for treating MDMA overdoses.
I thought the CTs were normal.
They were. Systolic's down to 70, heart rate's up to 130.
100 of ketamine, 100 of rock.
Could she have delayed bleeding?
It's not the chest. Pericardium's still clear. No tamponade, good EF, lungs are up.
She feels warm.
We'll check its temp. Meds are on board.
Belly is clear, no bleeding here.
She's loose.
Okay, go for it.
I see cords.
Looks good.
I'm in.
Video-assisted endotracheal intubation.
Good breath sounds bilaterally.
Temp is 102.4.
She has a fever of some kind. Does she have pyelonephritis that is now leading to sepsis?
Is this septic shock.
Okay, we need to assume the worst here.
Code sepsis, 2 sets of blood cultures, lactate, 30 per kilo of LR, and 4 antibiotics, ceftriaxone.
No, she was just in the hospital. Peptazo and Becco.
Because she was in the hospital, you need to have broad spectrum antibiotics added.
If this is sepsis, where is it coming from? What's the source?
Urinary tract infection.
She doesn't have one.
She did when I saw her.
It's not a UTI. We catheterized her urine a half an hour ago. There's no nitrates, 0 WBCs.
That doesn't necessarily rule that out. That points in the direction against it. More clinical judgment based on symptomatology. You needed to ask the patient if she earlier in the day had urinary tract symptoms and has a very high fever and has a white count. You're blaming the urinary tract infection all day long.
She was altered meningitis.
She's postpartum.
Endometritis. The CT of the uterus shows a thickened endometrium, but that's normal postpartum. No retained POCs.
It still could be the source. We'll do a pelvic after she's stable.
Either way, you're treating with antibiotics. Them trying to figure out what exactly the source is in this exact moment probably won't solve much.
Purulent drainage from the cervix.
Yeah, that is a sign of infection of the endometrium.
Oh, looks like we have our source. The positive urine this morning was contaminated.
Maybe.
Definitely. Not so clean catch specimen.
This infection's been brewing for a while.
So the car crash was a coincidence.
Not necessarily. She was probably already septic as the disease progressed, dropped her BP, and passed out while driving.
I mean, she wasn't hypotensive when she wrecked.
Adrenaline rush from the car crash and the sternal fracture raised her BP, but not for a while.
No history of fever.
Bet she was taking Tylenol for the pain.
Let's call ICU for an admit. Also want Guy to see her.
I mean, she had mild lower abdominal pain and a positive urine dip. No fever, no back pain to indicate pyelonephritis.
Yeah, I mean, I think it's well within the realm of making the right decision there. You can't know every medical diagnosis at every stage of patient presentation. Someone could come into my office and saying, I have a generalized bellyache. I press on the right lower quadrant, no pain, they have no fever, they have no white count, they're not vomiting, they just have a generalized ache. And they could say, doctor, I'm scared I have appendicitis because my brother had it. And I'll say, well, there's no sign that you have it right now, you just seem like you have a bellyache. But the important part is to give the reasons of when to return, what to look out for to make sure that they're safe, what are the red flags, where to go, who to call. For example, if your symptoms start getting worse, if they start migrating to the right lower quadrant, if you start vomiting, if you develop a fever, you need to come back. That's the correct way to make a diagnosis.
It just seemed like a simple UTI. I saw no reason to have her wait 8 hours for a bed for a pelvic exam.
Yeah, I think that's totally within reason.
Every postpartum patient needs a pelvic exam to rule out endometritis.
But how did she know that there was that she gave birth? It seemed like they just figured that out.
You're saying that with 20/20 hindsight.
Did you do a careful abdominal exam?
It was a quick chair exam and there was only mild tenderness over the bladder.
Perhaps there was something about the patient that made you overlook proper treatment.
Like what? Other than the obvious health risk factors.
Her size doesn't inherently make her unhealthy.
I mean, that's wild. No one is thinking that someone's size is leading them to have a UTI. This is like a weird connection to make.
Are you saying I was biased against the patient because of her weight?
I raise it as a possibility, not as an accusation.
Wow, I mean, I really don't think that's the case here. But I will look out for it.
And that's a great way to take feedback, especially with that very interesting flag to have raised. If you touch someone's abdomen and you examine it, and they only have mild suprapubic tenderness, they have no fever, whether or not they took Tylenol or Advil, if they say I have no fever, they have no fever on exam, they have a positive urine test, it's totally reasonable to think that they have a UTI. I mean, not knowing the backstory of the pregnancy, still, it's totally well within the reason to say that they have a UTI. Definitely need a cigarette after a day like that. Not recommending smoking, but I understand why she would need to do it. Interesting how medical providers are some of the biggest health hypocrites, in the sense of they know what the right thing is. Just because you know the right thing doesn't mean you're going to do the right thing.
Hard at work?
Oh!
I'll take my chances.
I mean, there's cameras everywhere. He's going to jail, but I hope she's okay. I've taken a meat punch before. You know that I've had 2 boxing matches, but did you know that I also reacted to UFC injuries? Click here to check that out. As always, stay happy and healthy.